Good evening, everybody. I am delighted to welcome you today to our webinar dedicated for the brain stimulation. The brain stimulation is an interesting for you. Today, we will some speakers will show you their experience and expertise in the field of neurosurgery and also in the field of neurosciences. This exciting topic is an intersection between the neurosurgery, neurosciences, and also new technology. And this interesting topic is a promise to you to provide you with a unique insight in the field of advancement, the latest advancement in this rapidly growing field. Today, we are honored to have three distinguished speakers. These distinguished speakers will show you their expertise, their practical experiences in the field of brain stimulation. The first speaker is Eman, Omer Elimam from Tbilisi State Medical University. Eman will discuss about the deep brain stimulation as a potential inducer of a Savant Syndrome. Then we pass to the second speaker, Professor Guenane. Professor Guenane Lakhdar is a Nigerian neurosurgeon from Mustapha Bacha University Hospital. And Professor Guenane will show you his experience about 99 cases. So he will show you how to avoid the failure in the surgical treatment of Parkinson disease. The last speaker is from Bhavani College of Nursing, Gilina Mari from Bhavani College of Nursing in India. Gilina Mari will discuss about comprehensive approach to enhancing brain stimulation and how to have the treating the neurological condition. After each presentation, you have the interactive section of discussion in which you can write the question in the part of chat box. Then the distinguished speaker will answer your question. So you have this opportunity to have a direct relation with our speakers. Throughout the webinar, we have some videos. For instance, Professor Guenane will show you some surgical video. So together, let's explore the potential and challenges of the brain stimulation in the context of neurosciences and clinical research. Let's go with the first speaker. Eman, you are here? Eman.
Dr. Nawal, for this great introduction and for welcoming us all. And I'm glad to be one of the speakers for today alongside amazing distinguished speakers. So today I will be sharing a topic that is very interesting to me, and it's actually me and my sister, who is Dr. Noon, BNMU Medical Faculty, and I am Eman from TSMU Medical Faculty. So my topic for today is primarily intriguing as a hypothesis. It's understanding the capabilities of our brain and briefly touching on neuroplasticity as a topic and how our brain has the ability to regenerate and to rewire its networking. So my topic is going to be unlocking genius, deep brain stimulation as a potential inducer of Savant Syndrome. And as I'm starting, I will touch on what is Savant Syndrome and why do we consider inducing it with DBS and what's that possibility. So Savant Syndrome is when we have a paradox of exceptional abilities and cognitive limitations together. And we see this quite often in patients who have autism, for example, where they will have limitations, cognitive limitations, or even lower level of cognition, but they have one exceptional skill. They're amazing in mathematics, or they're great artists, or so on. So this is called a savant skill. So savants have exceptional abilities in certain areas, but they have significant neurological cognitive limitations or developmental delays. So this is understanding what is Savant syndrome. We have some examples of very interesting people throughout the world and their savant skills. We have Kim Peek, who had amazing memory abilities to the point that he can read a book with both pages open at once, and he was able to read it and understand it. And this is an extraordinary skill. None of us is able to do that. And he's previously diagnosed with autism, and he now is suspected to have FG syndrome. So he also had a few other skills. So first of all, he could figure out anyone's birthday. So you could tell him you were born on which date, and he would tell you which day that was throughout any time of the years. So he can memorize all calendars. He can memorize all directions between any two cities or 2 points in the world by memorizing the map. And he was able to memorize Shakespeare plays in detail. So this was an exceptional skill for someone who was diagnosed with autism as well. Another interesting side as well, he was an artist. He will see a picture once and he will be able to draw the entire landscape just from one picture. So this was one of his skills, and he was also autistic. So this was a savant skill. Next, we have Orlando. Orlando had a traumatic injury. He was hit by a uh, ha- um, baseball in his left side of the on his left side of his head. And after that, after a few while, he just had headaches, and then he suddenly had ability to develop complex calendrical calculations. So he was able to know the day of the week for any date you give him and the time, and even tell you the exact whether this date was. So we're talking about throughout years, and this only happened after he was hit. So this was not a normal thing. He had a problem or like an injury, and then this happened. So one last person would be Alonso. Mr. Alonso had an ability of sculpting any sculpture you will give him to any animal you will ask him to sculpt. And he has a very low IQ, and he was also diagnosed with severe brain injury as a child. He suffered from falling. And even though all of this and his IQ being low, equivalent to 6-year-old, he was able to sculpt interesting sculptures as an artistic savant skill. So, what this tells us, Savant syndrome is a genius syndrome because it's a rare condition characterized by extraordinary skills or talents. It could be trauma induced, like we saw with the baseball injury, and associated with developmental disorders like autism or any injuries that can cause decreased IQ or retardations. Why does this happen? This is the interesting part of our brain's neuroplasticity and brain's function. So, why exactly is ununderstood, but what we know is that we have different parts of our brain that are dormant. And when we have an injury, we have a compensatory neural mechanisms due to this injury or due to this um, uh, illness or diagnosis they have. We have compensatory mechanism, and these parts of the brain become activated. So in savant skills, they have increased activity in specific brain parts, increased connectivity, and this is where we see our brain networking itself to enhance functions. For example, we know that people who have memory or linguistic savant skills, they have increased activity in left anterior temporal lobe. This was suspected and then confirmed by imaging. Parietal lobes associated with mathematical and spatial reasoning skills, and they are increased heightened activity in savants with these domains. So the studies suggest that the brain connectivity and activity plays a crucial role in developing savant syndrome. So now, where does DBS come into play? Where does brain stimulation and deep brain stimulation come into play? So when I was initially discovering this topic, I understand that deep brain stimulation helps us stimulate or regulate certain parts of our brain's neuronal activities. So when we also look back at the mechanisms, it could be that we have dormant brain areas that are then activated, or they're enhanced heightened activity. So DBS, first of all, it's implanting electrodes in specific parts of the brain, and it's a technique where they are implanted and electrical impulses are sent, and they affect the brain activity. And it treats certain medical condition, and manages our brain neuronal activity. So the
Excuse me.
potential, yes,
I think the slides are it's not changing. I'm not sure. It's fixed
sorry,
in the
just a
first
second.
page.
I can check again. Is it changing now?
Oh, no, we don't
Is
see
it,
that now.
just give me a second. Is it
You
changing
share
now?
your PPT, please.
It is shared. Is it sharing the screen now? Sorry, I'll try again. Okay, is it shared now? Okay, sorry. Um, all right. So deep brain stimulation, as we mentioned, is the using or implanting electrodes within specific areas of the brain. And it's the technique when the implants are surgically implanted and they affect the brain activity for certain medical conditions and they influence the brain
Please,
cells
Eman,
and the neuronal activity. Yes. Is
can
it
you
not
share the
shared?
PPT?
I'm not sure. Again, it's not working. Okay, is it working now? Is it sharing now, Dr. Nawal?
Yes,
Okay, is it shared now?
yes.
Okay, I'll keep it like
You
this.
can't
All
open
right.
it.
Yes, it's okay. I'll keep it like this so it keeps sharing. So again, this is the overview of deep brain stimulation. So, what is the mechanism of actions relevant to this? Is when we have neuronal modulation in DBS, it affects targeted brain areas and it alters these firing patterns of these neurons, and this helps us restore the normal functions in region in the brain that has abnormal activity. We can see this in movement disorders where we use deep brain stimulation. Neuroplasticity is promoted by deep brain stimulation because the brain is wonderful. It has the ability to recognize itself and form new neuronal connections. We're not saying by forming new cells and so on. No, we're talking electrical neuronal connections. And this is why it has a therapeutic effect and potentially could enhance cognitive function. Synaptic transmissions is also stimulated and modulated by DBS. So this allows us to adjust the balance of the neurotransmitters in the brain and overall improve the brain functioning. And this is where we're talking about, can deep brain stimulation unlock latent cognitive abilities? So, why this study or the focus of this concept in the first place? It's a theoretical exploration. We're saying the possibility, can we use deep brain stimulation to induce savant like abilities? And why will this be helpful? Because sometimes we have patients who have certain neurological delays. And if we can use deep brain stimulation to unlock these latent skills, this could be a compensation, a compensatory way where we can help increase the neuronal and brain activity in this dormant area and help combat this certain neurological delay. Again, it's a theoretical exploration. Targeted brain regions in certain parts of the brain. So if someone has a delay in memory or language, can we activate deep brain stimulation? Can we use deep brain stimulation to fix this memory or language delay that they are having or not? And hypothesis, it's a hypothesis that neuronal activities are enhanced or induced with deep brain stimulation. Briefly, certain studies showed that the brain can recognize itself in response to injury and lead to developmental of new skills. Studies of effective DBS can treat various cognitive and psychiatric conditions as well in some patients. And Savant Syndrome research, we need more research. So hopefully, if we all in the future or anyone who's interested in neurology, neuroscience, or neurosurgery can also focus on how can we use this knowledge and perhaps look more into how we can enhance the dormant parts of our brain. Um, so deep brain stimulation is can induce savant skills if validated. If we can confirm this study, if we can confirm this hypothesis, we can lead to a revolutionary therapies for patients. And this is going to offer new methods to develop and enhance skills in patients with developmental disorders or brain injuries. So this is where we can consider DBS as a savant skill inducer. So theoretical basis. So savant abilities may stem from enhanced neural connections and increased activity in specific brain regions. And the role of neuroplasticity, because our brain can rewire itself, this promises us for better cognitive enhancement And we know that the left anterior lobe is associated with certain things, parietal lobes are associated with certain things. And if we can heighten the activity in the required lobes, we can perhaps give patients a better outcome if needed. We're not going to be using it to create modern Einstein, but we can definitely use it for therapeutic purposes. Ethical implications are definitely important because we need to consider informed consent, autonomy, long-term effects, and research ethics when looking into this topic. And lastly, we need in-depth studies. We need clinical trials to confirm this hypothesis, if it could be done or not. We need methodologies. We need fMRIs, PET scans, and neuropsychological assessments on patients, and safety and efficacy of this. We need to know how the long-term effects are going to be. How is the patient's this neuronal activity is going to disappear after we remove or disconnect the DBS, or is it a permanent change? So we need to know all of this, definitely in-depth studies, but it's definitely an intriguing hypothesis to explore. Possible applications, we can use it for cognitive enhancement and for rehabilitation of our patients to aid in recovery of lost skills in our patients. And that's all from my side. These are the references if anyone is interested for the literature. Definitely, we need more literature in this regard. It was just a very interesting, intriguing topic to me and my team to look into. Any questions? And these, if no one has any direct questions right now, please reach out to us or my sister on LinkedIn and we will answer any other questions you have. I hope this was light and beneficial. And yes.
Thank you very much, Eman, for this good presentation. So for the attendee, if you have a question to Eman, Omer, Elimam, you can write them in the part of chat box. Yes? No question for Eman?
Maybe they will remember later and they can text us, definitely. I'm sorry, in the beginning, the slides were not showing, but you can also ask for the slides and I will share them if needed. Thank you so much.
Okay. After Eman, we have another speaker, distinguished speaker, Professor Guenane Lakhdar, who is recognized as one of the best neurosurgeons in Algeria who operate the Parkinson disease. In Algeria, we have a similar center which are occupied with the treatment and we treat this disease in Algeria. For instance, this week we have a 4 patient who will undergo the surgery in the department of neurosurgery of Lakhdar Hospital Center.
Thank you, my friend Habshi, for this presentation. I am very happy. If you want, I can beginning my lecture.
Yes, you can share your PPT.
Okay. Okay. Good afternoon, everybody. First of all, I would like to thank Dr. Habshi and the organization committee for inviting me to be a speaker at the International Live Conference on brain stimulation. Mr. the President, Mrs. the President, dear colleagues, we will talk to you about how to avoid failure in the surgical treatment of Parkinson's disease, about a series of 99 cases according to our experience in Mustapha Bacha Hospital in Algiers, Algeria. In order to avoid failure in surgical treatment of Parkinson's disease, the above factors are very important. First, have a good indication. The surgical procedure addresses to an idiopathic Parkinson's disease, have a good general health, normal cognitive and effective functional, failure of all drug strategy, good level of functioning when on and brain MRI in the normal age. The following are the criteria for surgery exclusion. multiple medical complication, dementia, severe frontal lobe dysfunction, severe depression, no adequate drug trial, poor libido response, patient unable to cooperate during surgical procedure, patient unable to cooperate during programming visit, severe cerebral atrophy, significant MRI abnormalities, and age more than 70 years old. Second, multidisciplinary team. The surgical pathology need a neurologist, a psychologist, a neuroradiologist, a neurophysiologist, a neuroanesthetist, and a coordinator, the neurosurgeon. Third, right time. In order to reduce the surgical procedure duration, we must do MRI and the planning a day before surgery and butt replacement 2 days after the surgery. This will reduce the time of surgery 2 to 4 hours instead of 6 to 7 hours. Other prefer to practice DBS, deep brain stimulation, and the general anesthesia in 2 hours. But the most of neurologists and neurophysiologists don't like it. Professor Marwan Haris in London prefer to do only a preoperative MRI and a postoperative check-up by MRI without intraoperative recording or macro stimulation. Properly locate to the final position of the electrode. Most of the neurologists and neurophysiologists don't agree with him, but practice increasingly in the world, especially in the USA and the United Kingdom. Fourth, right target and accurate placement. 3 targets are possible to stimulate or to be lesioned. Subthalamic nucleus, 75 cases, indication dyskinesia, hypokinesia, rigidity, tremor, globulus pallidus 3 cases, indication dyskinesia, L-dopa induced, thalamotomy or VIM, 17 cases, indication tremor, contraindication, these are 3 severe balance disturbance. Which surgical procedure would you practice, lesioning or deep brain stimulation? Reminding that lesioning is inexpensive, fast, no programming required, irreversible, unilateral treatment. Deep brain stimulation, presumably reversible, expensive, time-consuming, hardware problems, bilateral treatment. An example of thalamotomy for this young lady is of a tremor form, contraindication dysarthria, severe balance disturbance. Intervention, we can do lesionotomy or deep brain stimulation for the VIM. Pallidotomy or stimulation of the GPA, indication response fluctuation with dyskinesia, hypokinesia, rigidity, contraindication is dysarthria or balance disturbance in on. The third target is subthalamic nucleus for the tremor, akinesia, and dyskinesia. Reducing the treatment contraindicate the dyskinesia. As we can see in this slide, this young man in off, he walks slowly. In off. And in on, we can see him with severe dyskinesia and the thing didn't mal tolerated by him. There has been growing for the pedunculopontine nucleus. Enthusiasm for the pedopontine nucleus stimulation, encouraging report of the first study by Mazon and all. But however, the efficacy of this new target gate have not objectively a result or a good result. We have not experience in our department. In our department, we don't have any experience in the lesion and the stimulation of the pedoculopontin nucleus. In our department, we usually proceed MRI, head frame attachment, CT scan, and finally the planning 1 day before surgery. For the planning, we have, as usually, realized T2 MRI and coronal T2 allow us to clearly see the selected target STN, GPI in proton and sequence, or inversion recovery, and via VIM only and direct visualization. As you can see, we use in our department the two stereotactic frame, CRW, le Cosmer Robert Wells, and the Lexel frame. Without preference, both of are good for surgery and with Medtronic, Microdescender, and Inomed. As you can see on this, as you can see in this slide, an example of thalamotomy patients. As we can see in this, an example, when I increase the frequency in the generator, the tremor is stopped. And in this point, we do lesion test with 60 degree, and finally definitive lesion test with 75 to 80 during 2 minutes. And we can see the same patients in post-operative, in pre-operative, a tremor form, both of this side is a tremor, and just immediately after the surgery, you can see a thalamotomy, a left thalamotomy for the right side, not tremor in the right side. We can do thalamotomy only for unilateral thalamotomy. The localization target in DBS for STN need anatomical localization in imaging, electrophysiological verification by microelectrode recording, functional verification during surgery by macrostimulation, and finally, electrode placement control. Several methods are used in order to have the best target coordinate. First method, formula-based ACPC, undirected visualization. The second method, direct visualization of STN. The third method, a line drawing from the midline at the level of the floor of the third ventricle to intersect with the line drawing from the thalamocaudal groove parallel to the middle line. The fourth method is 2-2 axial, X is 3 mm apart from the meeting point of the limit and extend to red nucleus. Y does not change, and coronal cut Z subtract 2 mm from the Z, corresponding to the superior limit of the STM. And the fifth method is the Bijani method. It's very used now. Sixth, right electrophysiological evaluation. Best trajectory and see pulmonary activity, action, potential, NST recording reflect, reach hyperactivity, regular pulmonary activity. We go down with 5 electrodes, but only 3 electrodes which are in good position. Currently, we only use now 3 electrodes. Sixth is the right macrostimulation evaluation. The macrostimulation is done by the neurologist, which look for the best effect of the stimulation on the rigidity, on the tremor, and akinesia. The neurologist gives the best result in order to replace definitive DBS lead. 7 is avoiding side effect. The neurologist will test to search the side effect of the stimulation and conclude if it is in STN or in on the neighboring structure. Example, dystonia, tetanic muscles, contraction, dysarthria, if we stimulate capsula interna, inhibition of the L-DOPA effect, increased akinesia, substantia nigra, diminution of tremor if we stimulate zona incerta. Correct position is to show dyskinesia, reduction of the rigidity, tremor, and the akinesia. And finally, the electrode placement is controlled by X-ray in order to observe an abnormal stimulation of the DBS. The battery emplacement by subclavicular incision, and the definitive leads are connected to the battery by the extension, as we can see here. This is in the past with Medtronic pacemaker, and now we use Boston Scientific battery. This is for 5 years, and now for the rechargeable battery for most of the patients. Right stimulation parameters. Dear colleague, the aim of DBS programming is to stimulate STN and to avoid stimulation of the neighboring structure. Typically, initial programming of DBS is 2 to 4 weeks after DBS electrode implant. Subsequent programming can be every 2 to 8 weeks for the first 3 months, and then every 3 to 6 months after. Commonly take 6 months to obtain the best setting. Our series about 99 patients, gender 55 men, 44 women, aged from 37 to 66 years. We do 4 GPI, 2 lesionotomy, and 4 bilateral stimulation. VIM 17 lesionotomy, 4 bilateral in the beginning of the experience, and now STN 78 cases bilateral stimulation. Thalamotomy result noted good evolution of the EPDRS3 after surgery for the most of the patient, which is maintained several years later. The improvement of the EPDRS3 was evident. For example, patient number 10, 17, 25, 27, 36, 37, 44, and 46 have almost become normal, and the reduction of the medication by 50%. Therefore, the clinical symptoms have improvement until 70%. As you can see, the D of preoperative go from 59 to 55 is a good response to L-DOPA. And in post-operative, 1 month go from 34 to 15. After 3 months, it go from 99 to 53. This slide resumes the benefit effect of DBS to the tremor, rigidity, and akinesia 6 months, 1 year, 3 years, and 5 years later. Note the clear clinical improvement and the maintenance of this beneficial effect 5 years later after surgery. Some example, we can show this teacher before surgery of before surgery on immediately after surgery of medication on stimulation on medication and he kept the benefit of it 4 years later. On medication on stimulation here, on medication of medication on stimulation, and the same patient is observed 8 years after. She kept the benefit of the first intervention, and as we can see, when the patient is happy, also the doctor is happy also. This patient benefited from a thalamotomy first, where she maintained the benefit effect for 2 years, and after a recurrence of the symptoms, bilateral stimulation of the STN was carried out at home. Look him of medication before surgery and after thalamotomy, 2 years after. We can see him on medication before surgery, and we can observe him immediately after surgery. We can see him on medication on stimulation after surgery. Four years later,
she
kept the benefit effect of the intervention 4 years later.
Donc, Rahmani, 2 ans après l'intervention, on.
And 10 years later, the benefit of the intervention, 10 liters, to change only the body. This lady of medication, we can observe him with a tremor form and with severe dyskinesia.
Mais quand même, tu commences à sentir qu'elle est bloquée. Comment ça?
Before surgery. After surgery, 1 month after surgery.
ديري ديك اليمنى ولا هكذاك ديري مليح زليخه 1 mois après l'intervention on médication on stimulation دوري بلا قالوا شي بلا قال روحي زيدي هكذا
on medication on stimulation
هكذا
on stimulation
très bien 1 2 3 4 دير ديك الميك وجيبيها في هنايا ديري ديك اليمنى.
The last patient is Sherifi Murad. Before
Sherifi Murad,
tremor form,
en préopératoire,
severe dyskinesia.
on off médication. Yeah.
On medication before surgery.
C'est bon.
immediately after surgery.
شد الأخرى. Très bien, نوقف.
Of medication on stimulation in this slide. On medication on stimulation.
شريفي مراد on medication on stimulation 3 mois après l'intervention. زيد عاودوا لي روح عاودوا لي. لا سي مانيفيك الحمد لله. أي مراد. صور كيفاش كان.
Pardon. It's important to observe this image of post-operative control. On the right, good position of electrode at the STN level. Left, the electrode is lateralized, but with directional electrode, we can adjust the stimulation to the STN and have a good response of stimulation. Recently, we use this in our department. The complication, first of all, the classic complication, permanent complication infection along the path of the extension in 2 cases, pacemaker infection 2 cases, hypersexuality in 2 cases, transient complication frontal pneumoencephalus, intracerebral hemorrhage, more significant shaking, and asthenia in 1 cases, and apathy in 1 cases. Electrode infection in 2 cases, frontal pneumoencephalus transient complication in 6 cases, serious complications managed well with the neuroanesthetist medically. And in conclusion, the promising and the encouraging results with experience comfort us in the merit of deep brain stimulation of the subthalamic nucleus and the unilateral thalamotomy in the treatment of trembling form for patients with obvious Parkinson disease, and of course, the GPI DBS for the treatment of dystonia. Thank you for your attention.
Thank you very much, Professor Guenane. I would like to thank you warmly because you have a magnificent presentation. You share your experience and you add the attractive video. Thank you very much. You have a good explanation of the Parkinson disease. So for the attendee, if you have a question, you can write them in the chat box for Professor Guenane. The explanation enriched by the video gave more data, more essential concept about Parkinson disease. Do you have question for Professor Guenane? You have this opportunity to write the question in this part of chat box. No question? Jilina Mari from India is here. You are here?
Yes, ma'am.
Yes. Can you introduce yourself, please?
Yes, ma'am. Hi, good evening. I am Jelena Mary from Bhavani College of Nursing. I work as a nursing tutor. Thank you giving this opportunity, Elias.
Yes.
Hello, ma'am.
Hello.
Hello, ma'am. Are you hearing?
Yes, we are here. I hear you.
Shall I start my topic?
So the title of your presentation is Brain Stimulation,
Yes, ma'am.
Revolutionary Approach to Neurological and Psychiatric Disorder. You work in the collaboration
Yes,
with
ma'am.
Saint-Bernard. Okay, you can start your
Yes, ma'am.
presentation.
Okay, ma'am.
Okay.
Thank you, ma'am, for giving this opportunity. Welcome, you students. My topic is brain stimulation. In introduction, brain stimulation, also known as the neuromodulation, refers to this use of various techniques to enhance or restore brain functioning by applying electrical, magnetic, or other forms of energy to specific the areas of the brain. Okay, next. The brain stimulation means giving some more energy to the brain. Next definition. The brain stimulation is a non-invasive or invasive method of modulating brain activity using the electrical, magnetic, or other forms of energy to alter neural function with the goal of improving cognitive, emotional, or behavioral outcomes. In giving energy, we receive the emotional, cognitive, behavioral outcomes. We will improve to our stimulating therapy. Next. Next is the goals of brain stimulation. And what are the goals is there be? First, the primary goals of brain stimulation is first to improve the cognitive function. Cognitive function is the attention, memory, and processing speeds. And second is to manage the neurological and psychotic conditions, example depression, anxiety, and Parkinson's disease. These are all the psychiatric disorders. And in brain stimulation, we have to improve only the neurological and psychiatrical conditions. Third one, to enhance overall brain health and well-being, to improve our brain health and our body. And fourth one is to promote neuroplasticity and adaptability, to promote our ability of neural networks into the brain. Next slide, ma'am. Next, we have to move on in the types of brain stimulation. What are all the types is there? Just we have to see. First, in brain stimulation techniques, we have the three types of techniques. First, invasive, non-invasive technique, and second is the invasive technique, and third is the cognitive stimulation. In non-invasive technique, we have the four divisional stimulation therapy. First is the transcranial magnetic stimulation. Second is the transcranial direct current stimulation. Third is the transcranial alternating current stimulation. And fourth is the neurofeedback. First is the transcranial magnetic stimulation. That means it's one of the non-invasive procedure. Magnetic fields to stimulate nerve cells into the brain. Example means in depression patient, anxiety, and post-traumatic. That means PTSD also. It expands in this post-traumatic disorder. This technique of psychotic disorders patients, we have to use transcranial magnetic stimulation. Second is the transcranial direct current stimulation. It's one of the non-invasive brain stimulation. It uses the low level of electrical current to modulate brain activity. And we have to use the low level of current in this type of brain stimulation. And third one is the transcranial alternating current situation. It means the low quality, that means low intensity electrical current to modulate our brain activity. And fourth one is the neurofeedback. In this, it helps to people learn to control their brain waves. They are listen to control their waves. And second is brain stimulation is invasive brain stimulation. In non-invasive means it's not a surgical procedure. In invasive means also surgical procedure. In invasive, there are the four types is there. In deep brain stimulation, vagus nerve stimulation, and epidural cortical stimulation, intracortical microstimulation. What does deep brain stimulation mean? It's a surgical procedure. It's an electrical stimulation to treat our neurological conditions and movement diseases. And second is the vagus nerve stimulation. It means it's a treat to electrical impulses to stimulate the vagus nerve and stabilize irregular brain activity. And third one is epidural cortical stimulation. It also involves the placing our electrodes. Already we are placing through surgical procedure in placing electrodes on the dura mater to stimulate the underlying cortex of the brain. Next, fourth one is intracortical microstimulation. It means it's also the surgical procedure. Through the surgical procedure, is epidural and intracortical will be done. And this technique preciously stimulates cortical structures into the brain to restore the losing sensory functions. If the patient have lost the sensory function, we have to replace that. And third one is the cognitive stimulation. And this example is cognitive training and mindfulness meditation. And it's a range of activities and discussions that aim to improve cognitive and social functioning to the patient. Next slide, ma'am. Now we have to see the anatomical structures involved in the brain stimulation. There are the anatomical structures, certain cerebral cortex and lobe ganglia and ameldoma, hypothalamus. These are the main important parts into the brain. First is the cerebral cortex. In cerebral cortex, in this picture, we have to see the first frontal lobe, parietal lobe, temporal lobe, and occipital lobe. Now see the each lobe functions. And frontal lobe is functioning as an executive functions in motor control and decision making. In parietal lobe is functioning as sensory processing and spatial awareness. And third is the temporal lobe. It functions as a auditory processing and memory. And fourth is occipital lobe. It works as a visual processing. In see the picture, there are the situations of lobes. Next slide, ma'am. Next is the subcortical structures. In the structures, in this picture, you have to see the ganglia, thalamus, and hypothalamus, and amygdala. Now see the work. These are all the ganglia works in brain functions. And basal ganglia works as a motor control and habit formation. Thalamus works as a sensory relay, information processing. And hypothalamus works emotional regulation, autonomic functions. And amygdala works emotional processing and fear responses in our body. And see this picture, situations of basal ganglia, thalamus, and hypothalamus, and amygdala. Next slide, ma'am. Now we have to see the brain regions targeted by stimulation. What are all the brain regions targeting to the brain stimulation? These are five: and prefrontal cortex and motor cortex, sensory cortex, hippocampus, and anterior cingulate cortex. These are all the four cortexes mainly involved in brain stimulation. And now we have see the functions. And prefrontal cortex means works as executive functions and decision making. Motor cortex works as motor control and movement. And sensory cortex works as sensory processing in our body. And hippocampus works as memory formation and spatial navigation in our brain. And anterior cingulate cortex means error deduction and conflict monitoring in our brain. Okay, in first picture, in motor and sensory regions of the cortex, in the situations of prefrontal cortex and sensory cortex and hippocampus. And the these three are also located in first picture. Next, ma'am. Next slide. In this picture, you have to see the hypothalamus and midbrain, hippocampus, amygdala. This location will be shared in the second picture. You see, these are all the works as a stimulate our in our body to the functioning. And third picture, in amygdala is the main functioning into the our sensory cortex and movement cortex. And hippocampus and anterior cingulate cortex will be works by amygdala. Next slide, ma'am. Next, we have move on to the indications of brain stimulation. In indications of brain stimulation is the therapeutic indication, neurological indication, and psychiatric indication, and neurodevelopmental disorders, summons to. And first is the treatment-resistant disorder. Treatment-resistant means continuous treatment to depression. Second is the bipolar disorder. It's a usual shift in a person, mood, energy, activity levels, and concentration. The anxiety disorders, example, obsessive compulsive disorder and post-traumatic stress disorder. And fourth is the schizophrenia. Schizophrenia means serious mental illness in which a person confuses the real world and the world of imagination of, and often behaves in strange, unexpected ways of mental health. And next is fifth is the attention deficit hyperactivity disorder. The ability to sit and still and self-control. And next is the chronic pain management. And what are all the pain during stimulation also, some other diseases. And the patient chronic pain management, this is the indications of brain stimulation. And seventh is the Parkinsonism disease. This the Parkinsonism disease means uncontrollable movements in the mental health, in our body. Example, difficulty with balance and coordination. Next is a dystonia. Dystonia means involuntary movement. Dystonia means movement disorder. It causes the muscle contract. And ninth is the essential tremor. As a neurological disorder, it means involuntary shaking. 10th is the epilepsy, chronic neurological disorder that causes the person to have recurrent seizure, which are the brief episodes of involuntary brain activity. The chronic involuntary brain activity, the person only indicates to brain stimulation. Next, neurological conditions and stroke rehabilitation. After prevention of stroke, the patient may be some other indications for brain stimulation. Second is the sudden injury to brain. It's a traumatic brain injury. And third is the multiple sclerosis. That means long-lasting central nervous system disease. And amyotrophic lateral sclerosis. It's otherwise called as Lou Gehrig disease. Progressive degeneration of nerve cells into the spinal cord and brain. Next, fifth is the Huntington's disease. Huntington disease is an inherited condition in which nerve cells into the brain break down over time. Next slide, ma'am. Next is the psychiatric conditions also involved in brain stimulation. First is already we have to see the post-traumatic stress disorder and obsessive compulsive disorder and major depressive disorder and bipolar disorder and anxiety disorder. And next is the neurodevelopmental disorder and autism spectrum disorder. It's a neurological development disorder that affects the people interact with others, communicate and learn behave. Next is the attention deficit hyperactivity disorder. It's commonly in children and school ages. And third is the learning disabilities and dependent living and social functioning. And in a normal person, independent living and social functioning that in psychiatric patients is dependent to any another person. And next is the other indications. First is the addiction management. Drug addiction patients also involved in indications to brain stimulation. And second is the sleep disorders, example insomnia. disturbed sleep, and chronic fatigue syndrome, as the profound fatigue, sleep abnormalities, and pain in our body. And fourth is the fibromyalgia, and it's also the pain syndrome. And fifth is the neuropathic pain, and nerve malfunctions into the body. Next slide, ma'am. Next is the contraindications for brain stimulation. Now we have to see the indications only. This is the contraindications of brain stimulation. First is the metal implants in pacemakers and surgical clutch patients. Second is the pregnancy and breastfeeding. Third is the epilepsy or seizure history. In our history collection, the patient have a seizure. They are not allowed to brain stimulation. Fourth is the brain tumors or cyst. And fifth is the active infections. Next slide, ma'am. Now we have to come on the procedures. In pre-stimulation evaluation, in brain stimulation, first is the pre-preparation care is most important. First is the history collection. In history collection, we have to concentrate the medical history of patient and psychiatrical history of patient. And second is the physical examination. And third is the in physical examination, we have to concentrate the neurological disorder, nervous system, if any pain or some other, etc. And third is the laboratory test. Example, complete blood count test and urine analysis well done. And fourth is the neurological examination must done. And fifth is the psychiatric evaluation, mental status examination also done. And next slide, ma'am. Next slide, ma'am. Previous slide, ma'am. Okay. This is the procedure. Procedure for brain stimulation is the first pre-stimulation. In pre-stimulation evaluation, we have to see the evaluation. Now see the pre-stimulation care. First is the medical clearance from the healthcare professional. If the patient is correct condition to our brain stimulation, we must check medical clearance. Second is the remove metal objects, example jewelry, glasses, if any others. And third is the avoid electronic devices into the patient, example phones, pacemakers, etc. And fourth one is no alcohol or substance abuse. And fifth is the inform about medication and medical conditions. During stimulation, first monitoring and vital signs and discomfort to the patient. If any patient have a temperature, pulse, respiration, blood pressure and pain also, we have to check. And if any discomfort is there, we have to check during other stimulation. And second is the adjusting stimulation parameters as needed. If any other parameters is needed, that we have to find. Next is the maintaining patient safety and comfort and observing and reporting adversarial effects. During stimulation, if any other side effects is there, suddenly we have to report them. And providing emotional support and reassurances. As a nurse, must give a emotional supportive care to the patient in every procedure. Next slide, ma'am. Next, okay. These are all the pre-stimulation care and during stimulation care. Now we have to see the specific responsibility of the nurse. First is the electrode placement and maintenance. This one for the invasive methods only. And stimulator programming and adjustment and troubleshooting equipment issues. And fourth is maintaining infection control and sterilization protocols. And fifth is the participating in quality improvement initiatives. Maintaining infection control into the brain stimulation area. And next slide, ma'am. Now into the main procedures. We also already seen the types of brain stimulation that will be explained now. Okay, now non-invasive brain stimulation. In first is the transcranial magnetic stimulation. It means the non-invasive procedure, magnetic fields to stimulate nerve cells into the brain. Example is the depression, anxiety, and post-traumatic disorder patients. First is the positioning. Sit comfortably with head position in a TMS chair. Okay, coil placement. See the picture. The patient will be sit like this position. Sit comfortably. And coil placement. TMS coil placed on scalp, targeting specific brain area. And stimulation. Magnetic pulses delivered through coil, inducing electrical current into the brain. And session and duration is 15 to 30 minutes. We have to done this procedure. And frequency is 1 to 10 Hz. Next one. Next slide. Okay. The second is the transcranial direct current stimulation. It's one of the non-invasive brain stimulation techniques that uses the low level of electrical current into the modulate brain activity. In this procedure, we have to give the low level current to changes the brain activity. In this procedure, electrode placement, anode and cathode electrodes placed on scalp. See this picture, the patient seen that electrode. Wear that electrode. And stimulation, direct current applied through electrodes. And last procedure, we not use the direct current. In this procedure only, we have to use the direct current into the electrodes. Session duration 20 to 30 minutes. We have to give the procedure. And intensity means 1 to 2 mA. And next slide, ma'am. Next slide, ma'am. Okay, these are all the two I will explain. Next is the non-invasive brain stimulation. First is the deep brain stimulation. Invasive, it's a surgical procedure. Invasive means surgical care. And first surgical implantation. In this picture, we have to implant into the brain. And surgical implantation. Electrode implanted in targeted brain area. Battery placement, implantable pulse generator, IPG battery, implanted into the skin. And programming, IPG programmed to deliver electrical impulses. And stimulation, electrical impulses delivered into the brain through electrode. And follow-up care, regular adjustments and monitoring will be done in the surgical procedure care, regular monitoring will be done. Next, ma'am. In second is the vagus nerve stimulation. This also the surgical procedure. In surgical implantation, and see this picture, vagus nerve placement will be put the electrode implanted on vagus nerve only. The battery placement, IPG implanted under the skin. And programming, IPG programmed to deliver the electrical impulses. And stimulation, electrical impulses delivered to the vagus nerve. And electrical impulses only delivered to the vagus nerve. And follow-up, regular adjustments monitoring will be done in all surgical procedures. Next slide, ma'am. Post-stimulation evaluation. In all brain stimulation, we have to assess if the patient have any symptom assessment, cognitive assessment, mood assessment, and behavioral observation, and follow-up appointments. The symptom assessment means if any other side effects is there, we have to assess and treat them. And cognitive evaluation, if any other psychiatric and movement disorders, we have to evaluate immediately. And mood assessment, in the children, we must see the PTSD and ADHD care, and behavioral observation and follow-up appointment. If any other in non-invasive procedure, we have to follow up later also. In invasive procedures, suddenly we have to follow up and give a immediate appointment to them. Next slide, ma'am. Now we have to see the advantages of brain stimulation. And advantages, there are the types. First is the therapeutic benefits, improved mood regulation and enhanced cognitive function, and reduce the symptoms of depression and anxiety. Mostly we will prevent the depression and anxiety, and improve the motor control and coordination. We have to improve patient coordination through our communication, and enhanced focus and concentration. We must see the work and how they will work. Just see their concentration. And next is the clinical benefits. The first is the treatment-resistant depression management. If patient have a depression treatment, that will be how long days they have to take, and when they will cure, that will cure must be checked. And after giving this brain stimulation, and it's very useful for them. And reduce the seizure frequency in epilepsy. And when the patients have seizure and epilepsy, that will be reducing period. We have to give the brain stimulation, very useful to them. And improved motor functions in Parkinson's disease. And enhanced cognitive function in Alzheimer's disease. And reduced chronic pain. In clinical benefits, we have to see the Parkinson's and Alzheimer's and chronic pain diseases. These are all the ending of the management. We'll see their responses. And another way, we have to give the brain stimulation that will be important to them. Okay, next slide, ma'am. Okay, this is the research benefits and insights into the brain function and plasticity. Second is the development of new treatments and neurological disorders. We give new treatments to the brain stimulation patients and improve the understanding of neural mechanisms. And fourth is the advancements in neuroscience and research. And fifth is the potential for personalized medicine. We have to monitor the patient's personalized medicine in every diseases. Next slide, ma'am. This is the disadvantages of brain stimulation. And last, we have to see the advantages of brain stimulation. Who are all need brain stimulation, that we have to see the advantages. Now we have to see the disadvantages of brain stimulation. And side effects like a headache, dizziness, nausea, and skin irritation. And skin irritation like only in invasive methods only. And risks are, and first is a seizure induction. It's very rare. Risks are mostly rare. And there are the list just seizure induction and mania or hypomania and suicidal thoughts or behaviors and cognitive decline and infection or tissue damages. Next, ma'am. Now we have to see the follow-up monitoring. In any procedures, if non-invasive or invasive, we have to follow up and monitoring to the patient. First is the regular checkup with healthcare professionals. We have to appointment in invasive procedures, we have to give a yearly appointment to them. And non-invasive is the regular checkup, every checkup into the healthcare professionals. Second is the tracking symptoms and side effects. And in ward patients, if must be track to them if any symptoms like and last class the sir show the video like a tracking symptoms and side effects. And third is the adjusting stimulation parameters. And fourth is the monitoring cognitive and emotional changes. And fifth is the maintaining a healthy lifestyle. As a nurse, we have to explain how to maintain the healthy lifestyle. By following these guidelines, individuals can optimize the benefits of brain stimulation and maintain overall brain health. And through this follow-up and monitoring, the patient will improve their mental health and healthy lifestyle. Next slide, ma'am. Okay. First is the regular exercise and lifestyle modification. The patient, after follow-up and monitoring, they have to live with social society. Now, that time we have to see the lifestyle modification. If any lifestyle modifications is there. First is the follow. As a nurse will explain to them and follow up their lifestyle modifications. First is the regular exercises, example walking, yoga, and second is the balanced diet, example omega-3 rich foods will have must eat. Okay, the third is the stress management, example meditation and mindfulness work. And if any other stress, will do the meditation and work from with and mindfulness work. And fourth is the sleep hygiene, example 7 to 8 hours at night. Must as a human must sleep 7 to 8 hours in a day at night. First is the social support network, and the patient support to the society, how to communication, how to work with them, must they have to watch in a relatives or guardian. And nutritional considerations in lifestyle modifications, we have to see the balanced diet. In nutritional considerations, omega-3 fatty acids, antioxidants, vitamin B, and magnesium, potassium, and hydration. Must the patient have a hydration, and the body will be hydrated in every day. Next slide. Now I have to conclude my topic. The brain stimulation is a rapidly evolving field that holds immense potential for treating various neurological and psychiatric conditions, enhance the cognitive function, and improving overall brain health. With its non-invasive and invasive techniques, brain stimulation offers a promising alternative to traditional treatments. This treatment is the traditional treatment in invasive or non-invasive techniques. It's common procedure for every patient in psychiatric and neurological disorders. And through this brain stimulation, must the patient improve their brain health. And as a nurse, works as a patient, giving them more supportive care, and follow-up monitoring will be done through the patient recover.
Thank you very much for this educational.
Thank you. Thank you, everyone. I hope everyone
Thank you very
useful my
much,
PPT
Jelena.
class. If any doubts, ask me, ma'am.
Thank you so much.
Thank you, ma'am.
You present educational courses about brain stimulation. Thank you for reminding on all details on the brain stimulation. If you have a question for Jelena Mari, you can write the question in the part of chat box. It is an interesting courses on the brain stimulation. You gave all the details about the indication, contraindication, the evolution, all the details about the brain stimulation. You have a question? Don't forget to write in the chat box your mail in order to receive your certificate of participation. I noticed that today, any attendee asked a question about the subject of the brain simulation. It is very interesting for you. I hope that the information shared on this webinar will be useful for your practice. Especially thank also to our speaker for the recent contribution. Janina Mari gave you educational courses about brain stimulation, and Professor Guenane showed you how you avoid failure in the surgical treatment of Parkinson's disease. So see you soon, and thank you very much for your commitment.